11 नम्बर ब्लेड है त 11 नम्बर ब्लेडको एकदम पोइन्टेड हुन्छ स्वाट गर्दाखेरि यदि देयर इज नेजल प्याकको कुनै एउटा कुसन छैन भने चाहिँ सेप्टममा ड्यामेज हुँदो रहेछ सेप्टममा ड्यामेज भयो भने लड अफ ब्लिडिङ हुन्छ अनि यसको क्लु चाहिँ के हुन्छ दे विल ब्लिडिङ फ्रम द अदर पार्ट अफ द नोस्ट्रिल किन सेप्टमबाट अदर पार्टसम्म गएको हुन्छ है सो इट्स लाइक समटाइम्स कहिलेकाहीँ अब अब्जर्भ गर्दाखेरि चाहिँ डाक्टर साहब देयर इज ब्लिडिङ फ्रम अदर नोस्ट्रिल एज वेल त्यो नोस्ट्रिल एज वेल लड अफ हेभी ब्लिडिङ आई से डु द नेजल प्याकिङ इन बोथ साइड है त गट इट
You is also sometimes in early days you also put the tube को त्यो steel हुन्छ नि silastic tube को then you put it and there is bleeding you don't see it from inside then you put it all the way through the sac into the nasal septum then pull it with the artery forceps then you tear it बुझ्यो मैले भनेको यो ट्युब हाल्छ नि यहाँबाट हाल्यो हैन अनि भित्र काँचा ब्लडले गर्दा देख्दैन अनि तान्नु त पर्यो यसलाई बाहिर रिट्राइभ गर्नु पर्यो अनि रिट्राइभ गर्दा आर्टरीले रिट्राइभ गर्दाखेरि चाहिँ यो चाहिँ नेजल सेप्टमसम्म पुगेको हुन्छ when you pull it then it tears all the septum that is also
put this instrument this is paracord or needle holder from your neck that side then you'll see it in the ostium there you can feel it then take out get hold of your sinus tube with this tooth forceps and give that sinus tube from the tooth forceps to the paracord come out no need to use that hook I don't know how to use this
hook okay okay there are some easy points to manipulate we can discuss that in later courses है त हामीले लाइक we can जुन हामीले प्रो पनि हुन्छ नि त्यसैलाई पनि युज गर्न सकिन्छ सो लेट्स डिस्कस lateral सो म्यानेजमेन्ट चेक नेजल प्याक फर्स्टमा म्युकोजाबाट ब्लिड हुने बित्तिकै नेजल प्याक चेक गर्नु पर्यो अब कहिलेकाहीँ चाहिँ हामीसँग एकदमै एक्सेसिभ ब्लिड छ भने देयर इज समथिङ कल्ड एब जेल अर सर्जी जेल सो दोज क्यान बी युज्ड एज रिप्लेसमेन्ट intramucosal adrenaline plus lignocaine infiltration till blanching can be done and the most important and most useful part is adrenaline soaked gauze with pressure है त pressure pause nasal mucosa बाट ब्लिड भइरहेछ टेक अ पज प्याक प्रेस है त त्यो नै इम्पोर्टेन्ट हुन्छ है अनि अघि भने जस्तै ड्यामेज टु नेजल म्युकोजा छ भने बायोलेटरल गर्नु पर्यो सस्पिसियस गर्नु पर्यो ओके Okay.
Stop. Take a rest. Deep breath. Ask your assistant if you are scared. Ask your assistant. Then take a deep breath in where the breathing is from. Then you start it. So the foremost important thing is the surgeon should not be
Panic.
One thing that I have heard
career. Okay, so don't forget, recheck nasal pack and reapply, adrenaline soaked cottonoid pack or gauze with pressure, suction from wound site or nostril बाट पनि गर्न सकिन्छ कहिलेकाहीँ हेभी ब्लिडिङमा है त complete surgery rapidly with lacrimal intubation bleeding धेरै भएको छ भने there will be fibrosis हुने chances बढी हुन्छ bleeding blood clots हरू lysis हुँदाखेरि so you just put lacrimal intubation if there is heavy bleeding close muscle tightly and pressure pack we can use IV tranexamic acid TDS and so as Savita Didi has said when DCR turns bloody stop that is don't panic take a rest केही भएको छैन nothing has happened DCR will bleed अनि मलाई कहिलेकाहीँ भन्थे फेलोजहरूले ब्लडी भयो द्याट मिन्स द पेसेन्ट इज ह्युमन यु आर नट डुइङ अन अ रोबोट अर नट अन अ मेसिन है त इफ देयर इज ब्लिडिङ इन डिसिआर द पेसेन्ट इज ह्युमन सो डोन्ट प्यानिक स्टप प्याक विथ एड्रिनलिन सोक्ड पेलेट्स रिभन अर गज प्याक गर्ने एन्ड पज अहिले इमिडिएटली सक्सन गर्न जरुरी छैन सक्सन गऱ्यो भने झन् ब्लिडिङ हुन्छ है त सुरुमै प्याक गर्ने 1 मिनट 2 मिनट जिउ तन्काउने रेस्ट लिने अनि काम गर्ने है त सो अब त्यसपछि आइडेन्टिफाई गर्ने सक्सन गर्ने कटराइज गर्ने अरू छँदैछ स्टप प्याक एन्ड पज है त ओके सो गुड डिसिआर सर्जन्स डोन्ट फियर ब्लिड दे प्लान एन्ड देयर पज है त कति बेला पज लिने भन्ने प्लान गर्छन् सो विसिङ यु अल अ ब्लडलेस डिसिआर थ्याङ्क यू
surgery should be a bloodless surgery. Bloody discharge surgery are easy to a bad surgeon. Yes. And I've seen the cleanest surgeon in my residency from Dr. Savita. She does bloodless surgery all the time.
Now we need to move a little bit fast. We'll be now discussing on adjuncts, as it is not always necessary in this year, and not in routine cases. My topic is adjuncts in this year, tubes, MMC, and steroid injection. You. Now, this year surgery, as we have already discussed in so many topics, it restores lacrimal drainage pathway, failure often due to cicatricial closure of ostium, granulation tissue formation, or incomplete epithelialization. In these cases, we may need some adjuncts, like we will be discussing later. Coming on to first adjuncts is silicone tubing. Its main purpose is to maintain the lumen patency during healing. It may be due to there are two types of silicone tubing, bicanalicular and monocanalicular. Indication includes canalicular stenosis, revision discia, and traumatic cases. And as we have already discussed from our experts about various process of inserting silicone tube, it's my technique of inserting this here, a silicone tube. So my seniors, please guide me if I am wrong. Please. First of all, we'll dilate the punctum with natal shape punctum dilator and I'll check the patency with Bowman's lacrimal probe. I've started here directly with the silicone tube. First of all, we are going with, we are already dilated here, and we go from lower punctum usually, and from upper punctum. After retrieving both from in the lacrimal sac, in my setup, we generally do, we tie both the silicone tubes so that it won't come out from the nose. And from then, here we will do we can either retrieve it by inserting various instruments from nose, and but here I put it like in C-shape form. And it especially retrieve gada sajilo huँदो रहेछ as a surgeon.
You can do the same technique in endoscopic DCR also. You can put the same. There are a lot of ways you can do it, but this is a very good way. Also, विराट नगरको साथीहरूले गरिदियो अनि त्यसबाट हामी नक्सा टेक्निक भन्थ्यो है. Then we learned from them, but you can do it directly. The wire guides themselves outside. Very easy.
Similar process from the endoscopic surgery. Umang. This same process, we'll be seeing it from inside in endoscopic DCR. Here we have but it's very risky of injuring like a nasal septum in endoscopic DCR while retrieving it. But endoscopicमा चाहिँ त्यो हामीले त्यो भित्र नट टाइ नगर्ने भए चाहिँ अलि त्यो लामो छोड्नु पर्ने अनि त्यस्तो कि
I put a band. त्यो वाच ग्यालन ट्युबको ब्यान्ड राखेर भित्रमा
अलिकति तलबाट when we tie it endoscopyमा अलि माथिसम्म टाइट गरिदिने क्या otherwise it will come up from your punctum.
Yeah, that's the main problem in endoscopic DCR, silicone tubing. Now, not always silicone tubing is good. Some patient may come with cheese wiring or punctal cheese wiring or punctal sitting. As if we do एकदमै tightly silicone tube कस्यो भने, it may lead to cheese wiring, or there may be sometimes infection or caniculitis that may lead to severe adhesions, or there may be granuloma formations, or there may be tube prolapse from both upper and lower, as we have discussed in as I have experienced in some cases of endoscopic DCR. This case.
Tube prolapse के हुन्छ राहुला? What do you call that? Sign? Tube prolapse. You didn't have in your breakfast? Spaghetti sign, हैन? Spaghetti यस्तो लेखिन्छ हैन? Spaghetti sign.
Another adjuncts will be discussed. I'm not going to discuss about the management of the complications here. It is it's a long topic. Another topic, adjuncts, is mitomycin C. It's being anti-metabolite, anti-fibrolytic. It acts by inhibiting fibroblast proliferation. We use in the concentration of 0.2 to 0.4 mg and applied in soaked cottonoid at osteoma site for 2 to 5 minutes. The rinsing is very necessary after applying mitomycin C, as it is anti-metabolite. It is an anti-cancer drug, may lead to severe complication, systemic complication if gone site. Here is a video of applying mitomycin C. It's in external DCR surgery. Mitomycin C is not always required. In some cases, a failed DCR where there is traumatic cataract, it is generally placed. We'll leave for 2 to 3 minutes after applying it and rinse thoroughly with normal saline. Evidence on MMC, it improves ostium patency rates. It reduces granulation tissue formation and no significant increase in infection or delaying heal when used properly. It's best thing about MMC, but there is always side effects like bone marrow suppression, nausea, vomiting if it is not washed properly and taken systematic. Now let's go on to another adjunct, steroid injection. Agent we use is triamcinolone acetate, 20 to 40 mg per ml in periosteal submucosal near the ostium. It acts by anti-inflammatory and reduces granulation. This is a process of applying steroid. We generally don't inject directly. We place a abgel and inject steroid in that abgel and leave it there.
Next sir.
We are putting here abgel in it before closure of the flap. And we are injecting triamcinolone here.
Very nice flaps.
So here's a tip for the newcomers. Use of adjuncts is in selective case is necessary. When to use adjuncts, you should know it very properly. Avoid use of mitomycin C. And monitor tube position regularly, and follow-up endoscopy enhances long-term success. Concluding my presentation, is adjuncts enhances DCR outcomes when used appropriately. Evidences support selective use and individualized approach based on pathology and patient factor is necessary. So thank you. These are my views.
मेरो लास्ट चाहिन्छ चाहिँदैन होला है ओके आई थिङ्क इट्स नट नेसेसरी सो टुडेज प्रेजेन्टेसन लास्ट प्रेजेन्टेसन इज माई चाहिन्छ सबैजना अल्छिलाइसक्यो होला है ओके आई विल बी भेरी प्र्याक्टिकल because my topic is also very practical one, like DCR setup, what you must have, good to have and not necessary. I mean, it is like some may not agree with me, some may agree with me. I mean, what I may not think that it's not necessary, maybe necessary to someone, but I have in my 15 years of practice in doing DCR, what I have come today, so I'm giving you some tips that's necessary for it. Kun चाहिँ हो चेन्ज गरिदेऊ त this one हुन्छ so what is the most important thing that we must have? First is the patient, हैन patient चाहियो हैन so selection of patient is also very important. You don't do surgeries in acute dacrocystitis. You need patients with chronic dacrocystitis. So when whoever is doing surgeries in acute dacrocystitis will land up with failure. Okay, so one is the patient selection is the most important thing. You have to have a good patient selection. If you are a newcomer, when you are doing in first year, so it will be very interesting as well as difficult also because as Asis has already told, there will be bleeding because you tend to have bleeding. You have to know where bleeding will come from. So in first few years, you will have palpitation before doing DCR surgery. So it's normal. It's very normal to have bleeding huncha bhaneka. It will occur in your life, and you may ask. You are working, or everyone is working in a big center where you have lots of helping hand. You're senior, so never ever be overconfident that I can do it. Always ask for help. So asking help is not being low or not knowing. Afu sano hunuma, it's you have to. Your patient is the main thing. You have to do good to your patient. So the patient is one of the important thing you must have. Next, so. And the second most thing is your assistant should be also very good. If your assistant is good, then you will be very relaxed and you can do it very nicely. And other one is the ENT clearance. If you are an endoscopic surgeon, you can do it yourself, not necessary to send to ENT. You can do it yourself also. But if you are not endoscopic surgeon, like me, I send to ENT surgeon, get clearance. And sometimes I tend to see if I'm not sure that the ENT is newcomer, sometimes they write the same thing in all the patients. So I see the nose with, not with endoscope, with a torchlight and speculum. So you will have some idea that this surgery will be good. And another one, blood parameters. Blood parameters is also important, as there are some cases where there is hemoglobin level very low, platelets count, so you have to get clearance from the blood side. I know. Are you getting it? Okay. So next slide. Nasal packing. As already Prerna Assis has already told that nasal packing is very important. What I found in my working previously, like after doing nasal pack, I start to do surgery within 5 minutes. Don't ever do it like that. I mean, nasal packing should be good, and let them rest for 30 minutes, 20 to 30 minutes, so that the nasal mucosa will also be very, एकदमै राम्रो हुन्छ के त्यो nasal mucosa, they won't be bleeding, and the patient is also less anxious because they have time for half an hour, so they will be less anxious. If you start nasal packing गर्ने बित्तिकै, if you start doing surgery, then the patient will be very anxious and the blood pressure will shoot up and you will have bleeding and everything, complication will happen. So nasal packing is very important. Always do it before 20 to 30 minutes prior. So we usually use paracaine, or you can use xylocaine with adrenaline or an oxymetazoline. So nasal pack and a good forceps is very important. Another one you must have is a good surgical setup. Setup means you have a very clean, sterile environment of the OT, and one of the most important thing is a good source of light. Whatever source of light, you have to have a very good source of light. It may be in a form of microscope, it may be in a form of headlight, or sometimes if you have no microscope or headlight or whatever, you can use with a very good torchlight also. You can do DCR surgery in a very good torchlight also. I have done so many cases with torchlight also. So it's you can try also. There are good torchlights. You can do it also if you are in some places where you don't have a very good focusing light. You can use it. Ask one assistant to focus. It is a very good source of light. Some may not agree with me, but yeah, focus light is important.
One is diffuse light like surgical center. Diffuse light like that. Second one is diffuse light. But because you have to see the nasal mucosa, I think focused light like that headlight is more important than diffuse light. Some people can do in diffuse light, but main thing I think that if you want to really see the nasal mucosa, really see that your should be focused. The light should be.
Yes, but I find it very difficult to use this headlight. I have a neck problem, so I don't usually use the headlight. I prefer this focused, what you call, wall-mounted lamp. You have in Mechi also. So I have started doing DCR in Mechi since 2010. So this is 2025, so it's 15 years I've been doing DCR. So like I'm very used to do in that light, second one. So whatever preference you have, you can do it. So good focusing light is important. Next. And instrument, what you must have in your instrument. You have instrument over here. What you must have. Gulshan sir may not agree with me. Because Gulshan sir needs, he is very particular in everything. When I was doing resident, I have seen him doing DCR surgery, which I think I didn't understand anything. So now, but he is a very good surgeon. We have also learned lots from him. But I may be wrong, sir. What I use, what I must have in my DCR surgery, I am going to tell, which may not be. Oh yeah, Prerna also. So what first is you have to cut it. So you will need the scalpel, okay? So after that, what you do? After giving incision, Yeah, I know. So what we must have is, in any form of blade, you can use it. We use scalpel, 15 number blade. So this is must. After that, you should have a good catching forceps. Where is that? Tooth forceps, okay? So this is a tooth forceps, which must be good one. Not that one tooth is there and another is not there. So you land up, I know, maximum in Mechi. One tooth is there and one not. You are doing DCR? Hey, who is in Mechi? Yeah. I know, Mechi ma, I know, एउटा tooth हुन्छ, एउटा हुँदैन, कहाँ गयो? Oh, I don't know. I know, 2000 त्यतिखेरतिर त हामीलाई त्यस्तै दिन्थ्यो, कहाँ गयो एउटा टुथ भन्यो भने छैन डाक्टर साहब यही हो भन्थ्यो हैन, हामी त्यस्तोले पनि गर्थ्यौं हैन, तर like this one is very important. After that, हैन, what is this called? What retractor? Cat's paw retractor. This is very important, eh? I think, sir, this one is very important. So as I have already told that this is my preference, may not be preference to others, okay? It depends upon everyone, but this is very good. I know we have, I think Asis also have started DCR doing in Mechi. We all, whoever have started doing surgery in Mechi, we are very fond of this. Because if you have bleeding also, muscle bleed, angular vessel bleed also, you can manage with this. There is no need to panic, just manage with this. This is very important. It comes in different sizes. So small, big one, whichever you find it easy, you can put this. This is very important. I find it very important. And after that, what? What is this called? So, answer. I know. Okay, this is periosteum elevator. One of the important thing you have to put in mind to stop bleeding is you have to elevate the periosteum very nicely. If you have not elevated the periosteum very nicely, then there will be bleeding. So, एकदम periosteumलाई चाहिँ एकदमै राम्रोसँग अलिअलि खिसिखिसी गरेको हुँदैन, राम्रैसँग elevate गर्यो भने sac पनि मज्जाले छुटिन्छ हैन, नत्र भने if you are not doing this periosteum elevate, I mean complete, then the sac won't separate, okay? त्यो sac चाहिँ बीचबाटै त्यो च्यात्तिन्छ के हैन, so त्यहाँबाट पनि bleeding हुन्छ. So one चाहिँ यहाँबाट पनि we can stop bleeding है. अर्को के चाहियो? punch हो हैन, अब DCR गरेपछि त यो punch त चाहियो, यो त काम गर्दैन रहेछ क्या है. So what is this called? Carison punch, हैन, carison bone punch. यो पनि different sizes मा आउँछ, 2 mm देखि 4 mm छ. I find it very easy, 3.5 my best हैन, 4.5 हैन हैन, तर आफ्नो आफ्नो हिसाबले you have 2 to 4, 4.5, तर best 3.5 हुन्छ मलाई त्यस्तो लाग्छ हैन. And no any financial, तर मलाई चाहिँ त्यो इन्डो जर्मनको एकदमै राम्रो लाग्छ है, अरूको चाहिँ खासै त्यस्तो अब म चाहिँ त्यही युज गर्छु अनि बिकज इट हेज अ भेरी गुड दिस पन्चिङ हैन, पन्च एकदमै राम्रो हुन्छ. अरूको चाहिँ यहीँ बोन अड्किन्छ कि त्यसको चाहिँ बोन अड्किँदैन है. सो डिफ्रेन्ट कम्पनीजको डिफ्रेन्ट हुन्छ. दिस इज भनौँ न डिसिआर गर्ने मान्छेको त यो त हतियारै भन्नु पऱ्यो, यो भएन भने त वी कान्ट डु डिसिआर सर्जरी हैन. पहिला ट्रिफाइन के युज गर्नुहुन्थ्यो. म पनि रेजिडेन्ट गर्ने बेलामा हाम्रो सरले, उहाँ सरले त होइन अर्कै सरले चाहिँ गरेको देखेछु, यस्तो यस्तो गरेको के गर्नुभएको थाहा थिएन होइन, तर यस्तो यस्तो गरेको पुरा ड्याङ गरेको अर्थोको सर्जरी हेर्न गयो कि आई पढ्न आएको अर्थो आयो कि के भनेको, आई वाज सो कन्फ्युज. सो लाइक नाउ वी डोन्ट युज द्याट बोन एन्ड चिजल. सो दिस इज द वाट यु कल गन or यो नभइकन त हुँदैन हैन डिसिआर सर्जरी. सो
before using it, just do like this and see. It should be mobile like this. Should not be
यो चाहिँ अड्किरहेको छ नि त हैन. इट्स लाइक
what happens when you are a DCR surgeon, you should know how to take care of your instrument, because after surgery nobody is caring about this instrument. Some kind of fibers or the blood clots are here, that's why you have spoiled this machine. Otherwise
this one is also spoiled,
one punch is going to work for you for 1 to 2 years nicely if you know how to handle it.
So not 1 to 2 years, many years, होइन. अब अर्को है, अब यो त यस्तै भइहाल्यो. And so as Prerna, this one is punctum dialer, this is Bowman's probe, होइन. This is important, you must have. अनि needle holder, होइन, suture, 6-0 suture, Vicryl, होइन. So time is less. Nasal pack, what? No, that I have already told. So what good to have? होइन. अब for me, cautery and suction you can have, you don't need it. In my whole career, I think I have done 2 suction, none cautery. So I don't need cautery, होइन. But Dr. Prerna, होइन.
Not because for every case we need cautery, but if you happen to
Good to have, so it's good to have, but not necessary.
boost your confidence.
Okay. And that double action bone nibbler, as Dr. Home has already told, some in difficult cases, you may use it, but so it's good to have in your DCR set, but not necessary.
You can bend your hand like this and punch it. Otherwise, you can just get up, stand up, change your position and do it.
Orko. So like, this is also good to have. If you have an endoscopic setup and you are an endoscopic surgeon, it's good to have. And not necessary, as I have told this bone and chisel, I have never seen it doing nowadays. And high-end imaging in operating theater, expensive disposal kits, it's not necessary. So everyone has different needs, must have, good to have, and not to have. So for me, it's like this. You may have different opinion. Thank you for listening me. Okay.
Any questions, quick questions, we'll take it. Otherwise, we'll have a good photo. Then we will,
Pediatricians are there.
we'll leave the floor for the pediatrician. Any questions you can ask us quickly.
मेरो त्यहाँ मोबाइल छ कि सानो एउटा मलाई पठाइहाल्नु ल कहाँ जानु यहाँ You have to tell patient now you have a little pain. You have to have music system. You have to talk to patient. Yeah, you should have a vocal anesthesia more.
Good afternoon. We will soon be starting pediatric ophthalmology and neuro-ophthalmology session.
And tell patient that this music is for you, we are for you. There's no need to worry. I'm a very experienced surgeon. I know how my job. Please believe me.
Good afternoon, everyone. Welcome to the very special session, Pediatrics Ophthalmology. I would like to call on stage the moderator for the session, Dr. Samata Sharma. Over to her. Thank you so much.
Thank you, Rajni. Good afternoon, everyone. A very warm welcome to all of you. I'm Dr. Samata Sharma, and today I'll be moderating this session, which is Pediatric Ophthalmology and Neuro-Ophthalmology. So we have an exciting and insightful presentations today from some of the leading experts in Nepal, ranging from pediatric eye services in Nepal to pediatric cataract management, strabismus, amblyopia, and neuro-ophthalmology. So without further ado, let's begin the session. To start the session, I'd like to welcome Professor Dr. Anand Kumar Sarma sir to kindly to the stage to chair this session. Thank you, sir. I'd also like to invite Professor Dr. Sabina Shrestha to come on the stage and join here. Thank you, ma'am. I'd also like to invite Professor Dr. Srijana Adhikari to kindly join on the stage. Now I'd like to invite Professor Dr. Kavindra Bajracharya to kindly co-chair the session. Please kindly come to the stage, sir. So we are waiting for Dr. Purushottam Joshi to kindly co-chair the session. Dr. Purushottam, if you are here, please come to the stage. I think he must be busy somewhere. So let's begin with the presentations. Before starting with the session, I'd like to request all the speakers to kindly adhere to their time limits, and we'll have a brief discussion and a group photo at the end. So let's begin with the first presentation. Today's first topic is Pediatric Eye Care Services in Nepal, and Professor Dr. Sabina Shrestha will be presenting this. Professor Dr. Sabina Shrestha is well-known name in pediatric ophthalmology. She is the current president of the Pediatric Ophthalmology Society, and she is not only an ophthalmologist, she is an all-rounder with her good hold in poetry, literature, art, singing, and everything. So over to you, ma'am. Please come for your presentation.
Thank you, Dr. Samata. So my topic is Pediatric Eye Care Services in Nepal. So in 1981, when the eye survey, Nepal National Eye Survey was done, it has found that these red zones are the ones where there was more visual impairment, and depending on that, different eye hospitals were started all over the country. But what we see today is most of our eye care services, they were usually cataract-centered, which targeted only the elderly population. And this excluded around 1/4 of the population of the country from proper eye care. In 2020 census, approximately 28.8% of the population in Nepal was aged up to 14 years. And in Nepal, the first pediatric eye care services started in Nepal Eye Hospital with the first pediatric ophthalmologist, Dr. Narayani Shrestha. She was the first lady ophthalmologist of the country also. So these are some of the pictures of the pediatric department in Nepal Eye Hospital with the play area for the children. And now we have in the country, we have pediatric eye care services in all the tertiary level eye hospitals and also in the Center of Excellence. And regarding the pediatric ophthalmologist number, it is in total 43 pediatric ophthalmologists in the country. And whenever team of pediatric ophthalmologists, they work, we always run the school screening programs throughout the country. All the hospitals are doing this program. These are some of the glimpses of the screening eye camp at Thading. And whenever we go, as we all know, we don't complain about the terrain of the country. We go to those places where others don't reach. So this is hats off to the ophthalmologists of our country as a whole. So this is some of the pictures in Humla, where we had done the camp. Some few in Humla, few in Gulmi. And whenever we do the camps, like we have done few dedicated pediatric eye camps all over the country, which included the remote parts of the country. There, whenever possible, we did also the refraction. And when we did the screening in integrated schools where there were blind children who were studying with the sighted children. So in those schools, we did refraction. We also provided them with the low vision aids. And this picture shows the camp we had done in Cerebral Palsy Center. And the other one is in one of the integrated school where blind children were there, and we examined them. At Gulmi, we had done that. Similarly, before doing the camps, what we did, like we trained the female community health workers. So these are the pictures of training the community health workers. These are the pictures from, I think, Humla. So after that, female community health workers, they have the access to each and every household. When we teach them how to identify the sick eye or the diseased eye, they can refer those children to the camps whenever we did so. Similarly, we also train the teachers on eye health. And these are the pictures of one of the teachers training program. And we do the survey regarding the knowledge of the teachers on eye health before and after the training. And now, as the government has taken over, the government from its side also training the mid-level health professional on eye health. And it has started in the provincial level. So these are some of the pictures. This is one of Kathmandu, another is of Manang, I think. And what we have found, like refractive error is the most common ophthalmic condition encountered, and timely correction limits the development of amblyopia and strabismus, as we all know. And among those children who undergo surgery, cataract is the main cause. So what we have done, like vision screening, different people can do, even the students can do. So vision screening, it is the widely accepted means to timely correct the refractive error. For that, what we have done, we have started the vision clubs in different rural parts of the country. And students, they are trained how to assess vision in their own school and then refer the children who had vision less than 6/18 to the nearby eye care facility. So these are some of the pictures, students trying to take vision of their schoolmates. And this is one camp done in Humla again. So here we are collaborating with the local stakeholders before we organize any camps in those areas. And what we found, like many diseases of the eye, if sanitation is maintained, like diseases like conjunctivitis, trachoma, they can be prevented. So when we went to that place, we asked all the children to go to the tap and wash their face. So they have freshly washed face. The children are here in the picture. And we also give health education to the children themselves and also to the family whenever they come in small groups, we try to do. And this is one of the camp done in Thading, I think. So what is the way forward? So till now we have worked regarding the cure of the diseases, but now it is time for us to think about the rehabilitation. We have visually impaired children in our country, and most of them, they do not come to seek the help also, because most of the children who are visually impaired, they have multi-system diseases, and bringing those children to the hospital care also is difficult from the parents' point of view. And what happens, like when a child loses sight, in the beginning, they won't accept it. They'll be difficult to accept for the child themselves. And they try to refrain from the social activities. They don't like to join their friends in any games. They don't want to go to school anymore. So this rehabilitation is very important. And another aspect is like, parents, they must accept that the children has got poor vision and they should work for the rehabilitation of their child. Whenever a child is there, a healthy child with normal, good vision, what happens? The parents will like to take them to all the good places, but when it comes to the visually impaired child, they are slightly reluctant about it. So what I propose, like the parents should take their children who are visually impaired to all those places where they will take their sighted children. And social integration is very important. Like in a community, the people in the community, they may not know how to react with a visually impaired child. So they are also reluctant in interacting with children who have got poor vision. So these things, social integration is very important. Similarly, equal opportunities for the visually impaired children is of utmost importance so that they can flourish. Thank you so much.
Thank you so much, ma'am. Thank you so much for such an amazing overview of pediatric eye care services in Nepal. There wouldn't have been a better way to start the pediatric session than this. Now, I'd like to invite our next speaker. Our next speaker is Dr. Srijana Adhikari. She will be presenting on difficult situations in pediatric cataract. Dr. Srijana Adhikari is immediate past president of Pediatric Ophthalmology and Strabismus Society, and she currently heads the Pediatric Ophthalmology Department at Tilganga Institute of Ophthalmology. Over to you, ma'am.
Thank you, Samata. Good afternoon, everyone. So today in pediatric ophthalmology session, I'm going to talk a little bit about managing complicated pediatric cataract surgeries, how we face some of the very challenging cases in pediatric cataract management and how to deal with that. So I have no conflict of interest. To begin with, pediatric cataract, even the normal, simple pediatric cataract is a challenge for us, because beginning from etiology up to post-operative rehabilitation, there is a large difference between managing adult cataract and the pediatric cataract. So there are differences in everything: etiology, presentation, pre-operative evaluation, anesthesia, surgical technique, everything. So, and while doing pediatric cataract surgery, the basic things that we require is general anesthesia, which comes first, the good set of equipments, instrument, good biometry, efficient theater team, and our own expertise is needed. And the procedures usually is done in pediatric cataract surgery is lens aspiration, anterior vitrectomy, lens aspiration, anterior vitrectomy, and IOL implantation, lens aspiration and IOL implantation, lensectomy, anterior vitrectomy, and secondary IOL implantation. So all these depend on the age of the child, type of cataract, and type of surgery. So these are the things that we usually do in pediatric cataract setup. And decision making, unlike other adult cataracts, surgical decision making is the most important thing, pre-operative decision making. And the decision that we do on pediatric cataract mainly depends on age of the child, the cataract morphology, associated structural abnormalities which is usually present, and of course either it is unilateral or bilateral, that also matters a lot. And usually what are the things that we do decision on are the type of surgery, which type of surgery is to do, either PPC should be done or not, anterior vitrectomy is needed or not, either in IOL implantation now or can be put later. So these are the things that we have to make decision on. And apart from the normal cataract surgery, there are many a times the difficult situations like traumatic cataract, inflammatory cataract, subluxated lenses, pre-existing posterior capsular defects, cataracts and glaucoma, cataract with PFV, unilateral cataract, microcornea, difficult to dilate. So these all are the things that we face difficulties in pediatric cataract management. So to begin with, a little bit about traumatic cataract, which is very commonly, we find very common in our practice, and usually either it causes, blunt trauma also causes, and the penetrating or perforating injury both can cause the cataracts, that these may lead to the cataract. So these does not only come with the cataract, but it brings along with it so many other things, because any of the layers of the eye can be involved in this type of trauma. So it can cause angle recession, associated inflammation, sometimes very thick fibrotic membrane, vitreous prolapse, vitreous inflammations, and then proliferative changes, retinal detachment. So many things are associated because of the traumatic cataract. And there is always a challenges in managing the traumatic cataract. So surgical technique needs extra effort, extra instrumentations like microseizures and forceps. So during surgery also. Now putting the IOL, it's very challenging thing in traumatic cataract. When both the bag and the capsules are not present and the iris is not intact for the iris clip lenses, then the child, and when the child is very small for the scleral fixation lenses. So these are some of the situations where we cannot put IOL, and in that situation what to do? We can rehab with the contact lenses, but contact lenses is also a big challenge for developing countries like ours. So aggressive rehabilitation is needed, and whatever we do, it's so much effort from the parent side, so much effort from our side, but ultimately when the rehab is not done, then the child cannot get the vision. So that is very frustrating at times, unilateral aphakia, because of the traumatic cataract. And that is also a big challenge. And then the timing of the surgery, when to do. Immediately after trauma, we should do the cataract surgery and put IOL implantation, or we should wait for some time. So again, long wait, there is chance of amblyopia, and early surgery, chance of increased post-op inflammation. So we have to be very tricky on these situations. So at least we can wait for at least 6 weeks, and at the time we can do easily suture removal, cataract extractions, and IOL placement at the same sitting, so that no general anesthesia can need to be repeated. And usually the early intervention to be done if there is a ruptured capsule that is causing the increased intraocular pressure, or there is a vitreous prolapse, corneal decompensation. In those situations, we have to intervene early, and then later we can do the secondary IOL implantations. So these are some of the things which get challenges in the traumatic cataract. And other challenges like post-op inflammations, that is also very very common, and we have to give short-term oral corticosteroid is needed, long-term follow-up is required, and close follow-up for glaucoma, vitreoretinopathy. So these are some of the things. And other challenging cases are inflammatory cataracts, which we should always wait at least for 3 months in regular inflammations like uveitis, and GIA also sometimes we get, and we should always do cataract surgery under the cover of steroid. And if there is endophthalmitis and we have to do cataract, we have to wait for 6 months. Other conditions are cataract post-RD surgery, penetrating keratoplasty, trabeculectomy, and all your colleagues, they do very nice other surgeries, and sometimes it lands up in having pediatric cataracts, and they just refer these things to us, and it becomes very challenging for us to deal with these situations. And subluxated lens, always a challenge. And if it is larger than 180 degree, what to do? We have to do the lensectomy, anterior vitrectomy, and scleral fixation IOL is usually it is not appropriate. It's not usually put in younger children. So iris claw lenses is difficult to get here, and we have to rely on glasses or contact lenses, or mostly glasses, and then CTR can be, if smaller subluxation, CTR can be done, and later when the child grows older, we can do scleral fixation IOL if we are not putting the IOL at the same time. So these are some of the very challenging cases we get. And another one is microcornea and microphthalmus also. So when to put IOL whenever you get microcornea. So usually we do, if the cornea axial length is more than 18 millimeter and corneal diameter is more than 9.5 millimeter. Otherwise we do the cataract surgery, but we don't put the intraocular lenses. So I'll talk a little later whether to intervene for even the cataract surgery or not in the severe microphthalmic eye. So these are the situations, and again, difficult to dilate pupils intraoperatively. In those situations, we can very easily use intracameral adrenaline or combination of intracameral tropicamide phenylephrine. Pupil stretch, which is technically difficult. Iris rooks needs multiple suturing. We can sometimes use Gupta ring, but these are also difficult procedures. And cataract with pre-existing posterior capsular defect and cataract with the PFB is also challenging. So these are some of the intraoperative challenges, and pre-operative evaluation and planning is very, very important. So we have to do B scan. If anterior segment OCT is available, it's very, very useful. And and we have to think whether to put bag versus sulcus IOL. That is also, if we can detect pre-existing defect in the posterior capsule pre-operatively, then it's very easy to make the decision on to put the lenses in the bag or in the sulcus. So there are some of the cases that this is a simple pediatric cataract with a posterior capsular plaque, which indeed is a regular pediatric cataract surgery with a small plaque in the posterior capsule, which can be easily managed. So time only short, sorry. 2 minutes. So because of the time constraint, I'll just show some of the videos, some of the challenging cases. So in these situations, making the visual axis clear is the only thing that we can do, maximum we can do. Forget about lens and everything. So we can do that using the intraocular micro scissors that I did, and then clearing the visual axis. This is in these situations, we just land up facing pre-existing posterior capsular defect while doing pediatric cataract surgery. There is a large defect which is detected at the time of surgery. So this vitrectomy is very, very easy to handle the in-between vitreous prolapse and managing the vitreous which comes along while doing the lens aspiration. So this is very useful vitrectomy cutter, using the vitrectomy cutter to do the pediatric cataract surgery, which I always do, and I recommend everyone to do this if you have a facility. And then again, sometimes we get this type of cataract in which also making the visual axis clear will always only our goal. So, in some of the situations, even in the difficult dilate pupil, managing the pupil dilatation without pupillary stretch can also be done. So when this is the case in which I put intracameral and adrenaline, and sometimes even the breaking the synechia can dilate the pupil very well, and then you can easily do your pediatric cataract surgery. And sometimes in some of the cases, I'm putting the lens in this. And sometimes even in these situations also, if your cataract is very dense but it is very centrally located, and the peripheral area there was no cortex, nothing, so I just use the scissors to take out that plaque on the anterocapsule without dilating the pupil. So this is how we can manage some of the things. This is a very interesting situation. Just 1 minute. And this is in which there was subluxation, two types of subluxation in the two eyes. So one was posterior subluxation of the lens, and another one was anterior subluxation of the lens. In which situations, what to do? So in these situations, it's very difficult, and the child is small. So there is no other way to take out the lenses by doing the lensectomy and anterior vitrectomy. And usually what happens in the anterior subluxation, iris is intact, so we can put iris fixated lenses, but in this situation iris was also compromised, lot of atrophic changes, so we have to manage with the aphakia and then put the scleral fixation lenses later when the child grows a little older. So these are some of the cases that I wanted to present. Because of the short of time, I could not run all the videos. Thank you very much for your attention. And if you have any questions, you can ask later.
Your surgical videos are always a delight to watch. So we'll now continue with the next presentation. It is a visual outcome of pediatric cataract surgery in children aged 8 years and older. And I'd like to invite Professor Dr. Kavindra Bajracharya to present this. Dr. Bajracharya is a well-renowned name in pediatric ophthalmology. He is currently the Vice President of the Pediatric Society, and he is well known for combining clinical medicine with spiritual healing. Please, sir, the stage is yours.
यसमा छ होला है यो क्रस गरौँ Thank you, Dr. Samata. Respected chairs and all, good evening. I'm presenting one of the study we did at Lumini ICU. It is the visual outcome of pediatric cataract surgery in children aged 8 years and older. I don't have any financial conflict of interest to disclose. Coming to the introduction, early cataract removal and intraocular lens implantation is considered the most appropriate treatment to avoid irreversible amblyopia. The period of plasticity for visual maturation extends until the age of 8. The age of cataract surgery is important as delay in surgery affects the overall visual outcome. The aims and objectives of this study, the general study was to determine the visual outcome of pediatric surgery. Specific objectives were to explore age, gender, and laterality, to find out the morphological types of cataract, and to determine improvement in visual acuity after cataract surgery in 8 years and above. This was a retrospective discrete study for 1 year from January 2022 to December 2022. The study enrolled 8 years to 16 years old congenital and developmental cataract presented in pediatric ophthalmology and strabismus department of LEIRC. Data were collected in terms of demographic information, preoperative visual, corrected visual acuity at pre-op, post-op day, and at 3 months post-op. The study also recorded laterality, morphological types, and a specific type of IOL implanted. Cataracts other than congenital and developmental cataract were excluded. Total of 48 congenital and developmental cataracts were operated during those years, and the mean age was 10.56 years. Among them, 13% involved right eye only, 17 left eye only, and 18% with bilateral involvement, with total 66 eyes. There were 26 male, comprised 54%, and female was 45%. Among the cataract cases, lamellar cataract was the most common type, 81%, and other types of cataract included total cataract, absorb cataract, posterior polar cataract, posterior lenticonus, lentiglobus, etc. Cataract surgeries were performed under local anesthesia in 33%, whereas 66% surgery underwent general anesthesia. Rigid polymethameta-acrylate lenses were implanted in 40 eyes, and foldable IOL were implanted in 26 eyes. Nystagmus and squint was present in 8% each. Before surgery, base-corrected visual acuity was in normal range, 6.6 to 6.18 in 14 right eyes, 45%, and 40% of left eyes. On post-op day, 23 eyes had 74% had this vision, and 42% in left eye. After 3 months of follow-up, 24 right eyes, that is 77%, and 20 left eyes, 57% achieved normal vision. On average, BCVA ranged from 42% at presentation, whereas after surgery, 3 months, 66% achieved this range. So the mean age was 10.56 in our case. In previous studies by Thakur, Jaya et al., 11 years was median age. Among developmental and congenital cataract, unilateral presentation in our studies 62%. It is dissimilar to a study by Kennett et al., who studied in infants. Bilateral presentation was 61%. It suggests that bilateral cases present sooner than unilateral. In this study, 54% were male. In previous study in our hospital only, below 8 years, male is to female ratio was 2:1, and study by Negriti et al., 63% were male. Delayed pediatric cataract surgery often result from insufficient awareness and also the financial constraint in developing country. Late presentation of cataract could be because they have some amount of vision good enough for daily work, The lack of awareness can be another cause. Amblyopia and nystagmus limited visual outcome, indicating need for earlier detection and treatment. So as mentioned earlier, 42% was between 6'6" to 6'18" pre-op, whereas 66% after 3 months acquired this vision. So to the conclusion part, it is not uncommon for pediatric cataract to be presented at a later age. Unilateral cataract is common presentation in children who present late. The finding indicates favorable visual improvement following cataract surgery in children aged 8 years and older. For optimal visual outcomes, pediatric cataract surgery should be performed as early as possible. The limitation of this study is that the sample study was small, so with large sample, the study can be more conclusive. And the comparative study, younger than 8 and above 8 years, can be more conclusive to find out the visual outcome after 8 years is favorable or not. So thank you.
Thank you so much, sir, for such a wonderful presentation. And you have such a vast experience in pediatric cataract surgery, and you say this is such a small number of patients, but from where we see it's a huge number of pediatric cataract surgeries that you have been performing. So moving on with the next presentation, our next presenter is Dr. Rosita Parajuli from Telangana Institute of Ophthalmology, and she will be presenting on ocular complications of strabismus surgery at a tertiary eye hospital in Nepal. Over to you, ma'am.
Good evening, respected chairs and everyone. Today I am going to present on a study conducted at Telangana Institute of Ophthalmology, and it is about the ocular complication of strabismus surgery at tertiary eye hospital Nepal, a retrospective review. First of all, introduction. Strabismus surgery is generally safe, but it is not without potential complications. Understanding the type and frequency of complication is crucial for improving the surgical technique, setting patient expectations, and enhancing the post-operative care. And there is limited data on complication profile from Nepal. And the main objective is to identify the types of complications following horizontal strabismus surgery at tertiary eye center in Nepal. In methodology, it is a retrospective review of medical records conducted from 2017 to 2020. And all the data were recorded from EMR retrospectively. About 206% were collected in the study, and only 194% has complete data, so they were enrolled in the study. And the follow-up period was 3 months, and the patient with restrictive muscle disease, paralytic squint, and vertical squint were excluded from the study. In clinical evaluation, vision was taken by Snellen chart and Leah symbol. Extraocular motility was measured in 9 cardinal gaze, 9 position of gaze. Angle of deviation was measured by prism bar cover test at both near and distance, with and without glasses. And modified Krimsky test was used for patients with poor vision. Stereopsis was measured by tetanus fly test, and binocular vision was measured by Watford dot test. Surgery was chosen according to the type of deviation, presence of amblyopia, and age of the patient. Younger children and those with alternating squint, bilateral surgery was done, and older patient, monoocular surgery was done. And in post-operative period, patients were examined on first post-operative day, 1 week and 6 weeks and 3 months period. And data entry and cleaning was done in MS Excel, and data analysis was done by IBM SPSS version 20. And coming towards results, 160 patients were between 6 to 18 years old, and median range was 17 years old, and there were 95 male and female were 99. Overall complication rate was 12.4% among 194 patients, and 87.6% there is no complication, and 2.6% patient has conjunctival cyst and conjunctival wound dehiscence. And 5 patients has conjunctival cyst. The cyst in the patient which have cyst, only the 1 patient needs the excision, and 5 patients has conjunctival wound dehiscence which require resuturing. 4 patients had corneal epithelial defect which was healed after patching and antibiotic treatment. 4 patients had steroid responder which was controlled after anti-glaucoma medication and after stopping the steroid eye drops. 3 patients had post-operative diplopia. All the patients were comfortable after using the prism glasses. 2 patients had corneal Delen, which was improved after lubricating and antibiotic eye drops. 1 patient had suture granuloma, which was improved after suture removal and antibiotics and steroid eye drops. In gender distribution of complication patient, male were 14 and female were 6. Now in discussion, one MJ et al. Reported that corneal Delen developed in approximately 3.2 to 4.3% of the establishment surgery. However, middle rectus reoperation and rectus muscle transposition, the incidence is significantly higher. Yorduk et al. Reported that corneal Delen was the most frequently detected complication of establishment surgery, and all the patients had undergone surgery using a limbal approach. So, the smooth closure of the limbal wound and trimming of the excess limbal conjunctiva are recommended to prevent tissue elevation near the limbus. 5 patients had developed conjunctival cyst. Among them, 3 were temporal cyst and 2 were nasal cyst. Younger age is considered as the risk factor for the cyst formation, which typically occurs at the site of muscle reattachment and during muscle recession procedures. Cysts may develop even after a decade of surgery, which can present as a gradually enlarging mass or as a recurrent strabismus. Persistent cases often require surgical excision, or although spontaneous resolution may occasionally occur. 3 patients developed diplopia after surgery, 2 were children and 1 was adult. In the first case, bilateral middle rectus recession was performed for esotropia. 1 month post-operatively, he had a residual esotropia of 10 base out R/L4. In second case, left eye LR resection and MR resection was performed for left eye exotropia with nystagmus with omlapia. At 1 month patient post-operatively, he had 12 base in at near and distance. In third case, left eye LR resection and MR resection and inferior transposition of LR and MR tendon was performed for left eye exotropia with hypertrophy. During follow-up, he had conjugative exotropia 12 base out at near and distance 4 L/R. Wow. And 4 patients had raised intraocular pressure. And in conclusion, overall complication rate was 12.4%. Most common complications were related to the conjunctival wound dehiscence and corneal surface. Vision-threatening complications were rare. Majority of the complications were successfully managed with conservative measures and minor interventions. Now, clinical implication and recommendation. Meticulous surgical techniques is vital to prevent the wound dehiscence and cyst formation. Close monitoring for corneal issues and IOP elevation is essential. Patients should be informed about the common non-vision-threatening complication and likelihood of successful resolution after surgery, and discuss the possibility of diplopia and its management option are pre-operatively. Limitation of the study is It is a retrospective design and a single center study. Findings may not be fully generated to all the settings in Nepal, and follow-up duration limited to a minimum 3 months. Later onset complication may have been missed. These are my differences. Thank you.
So now moving forward, I would like to call Samata herself to talk on myopia, the newer perspectives, which indeed is a very hot topic these days, and so many things very fastly going on in myopia. So she will talk on myopia.
Thank you so much, ma'am. के भयो Once again, good afternoon to all of you. So I'll be dealing with my newer perspectives in myopia management. So what is myopia? Our past understanding was myopia was simply considered as a refractive error that could be corrected simply with the help of glasses or simple contact lenses. But now, the definition of myopia has evolved and changed with time. So we can now say, this is the Gen Z definition of myopia. So it states that myopia is a progressive eye disease which is characterized by abnormal axial growth of the eye, including significant risk of vision-threatening complications, and it requires a comprehensive management approach. So why are we talking so much about myopia? It's because of the potential complications of progressive myopia. So there are several complications like glaucoma, cataracts, retinal detachment, and myopic macular degenerations associated with myopia. Yes, risk increases significantly with higher myopia severity, but even the low myopia carries substantial risk for complications. So when we look at the statistics, it's alarming. So with the statistics, we can say that the myopia now is a global epidemic, and it is projected that by the year 2050, that 50% of the world's population will be myopic, and 1/5 of them will be at the risk of blindness. So there are several terms in myopia treatment. The first one is myopia correction. So myopia correction simply implies refractive error correction either with spectacles or contact lenses. Other one is myopia control, which is a broader term which includes refractive error correction along with measures to stop progression of myopia. And third one is a myopia management, and this is the umbrella term which includes myopia control, monitoring, lifestyle modification, and management of myopia-related complications. So the comprehensive myopia management strategy includes baseline assessment, then correction strategies along with optical interventions and pharmacological treatments, then monitoring the progression of the disease, then also prescribing the lifestyle recommendations. So why does myopia progresses? For this, we have to understand the axial growth mechanism. So what is the abnormal stimulus for axial elongation? When we correct myopia with simple glasses, what happens is the central rays of light, they are focused directly into the retina. But the peripheral light rays, they are focused slightly behind the retina. And this is known as the hyperopic refractive defocus. And this hyperopic refractive defocus is the stimulus for axial elongation, because when this light rays focus behind the retina, the stimulus goes to the brain that the eye is short, so that the light rays are focusing behind the retina, and it gives the stimulus for the axial growth. So normal growth is 0.1 millimeter per year, and it occurs most rapidly during the childhood and slows down with age. And to start the preventive intervention, we have to identify true myopia and remove the pseudomyopia. For this, we have to do the cyclorefraction, then start optical intervention, not just with the simple glasses, but with peripheral defocus glasses, and also start pharmacological interventions to slow down the progression. So there are some common misconceptions associated with myopia management. The most common one is undercorrection. Myopia has been undercorrected since ages, but that doesn't work. So what works? We have several evidence-based practices which say peripheral defocus design, low-dose atropine, and orthokeratology. These are the evidence-based approaches to slow down myopia progression. So when to initiate myopia control? So there are certain things to keep in mind. The first one is early onset myopia. If the onset is early, it is more likely to progress rapidly. And also if there is positive family history, and if the annual progression rate is more than 0.5 diopters, then it's the indication to start myopia control approaches. So after we start the myopia treatment, we have to do the continuous monitoring to find out whether it is actually progressing or not. So for this, we have our optical biometer. So optical biometer is the high resolution. It can detect even smallest changes in axial length. And its most common advantage is that it's non-contact and suitable for children who are mostly non-cooperative for the contact techniques. If it's not available, then we can go for ultrasound biometer. We also have specialized myopia management equipments and other softwares to detect myopia progression. So for optical interventions, we have peripheral defocus spectacles which create a hyperopic defocus so that the light rays, they converge in front of the retina rather than behind the retina, and this stops the stimulus for the axial growth. We have various technologies like DIMS technology, CARE technology, HALT technology, which are based on this peripheral defocus. Another one is contact lens. Multifocal, bifocal, soft contact lenses, and especially orthokeratology lenses, they have been proven very effective in controlling myopia progression. They are worn at night, they reshape cornea, and you can be spectacle-free whole day. And we have other pharmacological approaches, and this low-dose atropine is the most commonly used, and it's an optimal range for myopia control. It's 0.02 to 0.05 concentration. And we have combined therapies with low-dose atropine and peripheral defocus glasses. Also, orthokeratology can be combined with low-dose atropine, but it is based on personalized approach. We should consider the lifestyle factors, like if the child is very active, we have to go for contact lens instead of spectacles. Economic consideration, financial capacity of the parents is also important, and also psychological impact. Because of the glasses, child may have psychological impact. They don't participate in school activities, decreased social interactions may be there. So we have to consider these as well. And outdoor activity is a natural intervention. More than 90 minutes daily is the recommended one. So in summary, we should think beyond the myopia correction only and focus on preventing progression of myopia and myopia-related complications. Thank you for your kind attention. Now moving on with the next presentation. Before moving on to the next presentation, I'd like to welcome Dr. Sopan Samon in this hall. Thank you, sir, for being with us in this session. We are truly honored to have you here. The next presentation is management of Duane retraction syndrome with offshoot, and I'd like to invite Dr. Sulabh Karki to present this. Dr. Sulabh Karki, can we have you on the stage? Oh, thank you.
Hello. So, respected everyone, I am Dr. Sulabh Karki, fellow at Mechi Eye Hospital. And at first, I would like to welcome every delegates to have their presence at this Noscon 2025. So, she is a 25 years young girl who presents to our OPD with the complaints of diminution of vision of her left eye since childhood. At the same time, she also complains of deviation of left eye. On examination in all gazes, she had limitation of movement on both abduction as well as adduction of the left eye with significant offshoot. So this is the video. We can see the retraction, there's a limitation in abduction as well as adduction with retraction and offshoot. So there's a narrowing of the palpebral fissure along with the offshoot while trying to adduct her left eye. And her anterior and the posterior segment evaluation were normal. And this was the orthooptics evaluation, the left eye being hypertropic as compared to the right eye. And the deviation in the primary was less as compared to a secondary deviation. So from history and clinical examination, the three differential diagnoses were made. At first, the Duane's retraction syndrome. Second, the lateral ictus palsy. And third is the being congenital iso or exotropia. So the lateral ictus palsy was excluded because she had no any symptoms of diplopia, as well as there was restriction of movement in both adduction and abduction. Similarly, the strabismus was also ruled out because there was significant offshoot, as well as restriction was noted along with narrowing of the palpebral fissure. So the tentative diagnosis of Duane's was made based on the co-contraction of both the lateral and the medial rectus, along with the limitation in both adduction and the abduction, along with 5 to 8 degree head turn measured by goniometer. So this is the basic pathophysiology. The oculomotor nerve, which commonly supply all the extraocular muscle except the lateral rectus and the superior oblique. The lateral rectus muscle that is supplied by the sixth nerve or abducent nerve, it undergoes hypoplasia or agenesis, due to which the neurotropic factors are being released by the lateral rectus, and as a whole, and as a result, the oculomotor nerve, the part of it supplies the lateral rectus muscle. So that's why the co-contraction and the globe retraction commonly occurs. So this is a simple video demonstrating. So during the trying abduction movement, the globe simply retracts up and retracts down, despite of, the indication, the surgery was performed in this patient. The indication being the misalignment of the eye in primary position, that is significant exotropia was there, abnormal head posture, measured about 8 degree with significant offshoot and narrowing of the palpebral fissure. So basically the muscle at first was disinserted and it was splitted into two halves. And both of the halves were cut separately. And then around 8 mm of the size was measured. And then the globe, both the halves were splitted at a Y-shaped, and then Y-shaped recession was done. We can see that both the upper and the lower limb are being stitched separately. about 8 mm behind its insertion site of lateral rectus muscle. And here can be seen that the two halves are being splitted totally up to their posterior. And then the conjunctiva was added here and the autograph was made. So basically, the main practical reason behind splitting of the muscle was to disinsert the lateral rectus muscle from the crest of the eye and to split into two halves such that the significant offshoot as well as narrowing of the palpebral fissure was limited. And this was our second postoperative day, and we can see that no significant offshoot as well as narrowing was seen. And there are various articles that was initially published, that is isolated Y splitting and the recession of the lateral rectus muscle in the patient with exudations was effective. This was published in National Health Journal. And Y splitting is proved to be an effective therapy. So the key takeaways was being Y splitting of the lateral rectus in drainage retraction improves globe retraction and significant offshoot. And when combined with recession, it also improves the eye alignment and also helps the need for the abnormal head posture. Thank you.
Thank you, Dr. Sulab. That was a very nice case presentation. Duance has always been a challenging case for all the strabismus surgeon, and that's a wonderfully managed case. Now, we would like to move to the next presentation. Our next presenter for today is Mr. Rohan J.K. Imlani, and he will be presenting on eye screening of children and adults at rural Nepalese schools. Please.
It's not reading it. It's not reading it. Is there a way to connect it to the internet? If we can connect it to the internet, I could easily download it.
Isn't it working?
Yeah, it's just, I think it's my problem with my USB. I think it's corrupted. Is there a way to connect to the internet?
No, I don't think it's connected.
I just tried. The Wi-Fi works.
So if it's not working, you can just fix it till then we can continue with the next presentation.
Yeah,
Does it sound good?
I think it's corrupted. It might be.
Okay. No.
Is there a way to just connect to the internet? It'll take 2 minutes to get the file on the computer.
No, but the technical guy, he has just gone, so they will call him, so it will take some time. So we'll move on with the next presentation.
Sure.
Till then you
Absolutely.
can fix it.
Sure.
Okay?
Absolutely.
Sound good?
Yep. Thank you. I think I could download it. Is it okay?
Yeah.
To the computer? Yeah.
So we are facing a small technical glitch here. Till then, if anyone has some questions, you can ask to our panelists or to the presenter. Even I'm new to here. I'm just moderating. I don't know about this computer, so I'm just... Okay.
Sure.
So we are facing a small technical glitch here. So we'd like to carry on with the next presentation. So I'd like to call upon Ms. Anju Kumari Mahato to present her topic, which is perspectives on the quality of life of children undergoing occlusion therapy and their parents. Please kindly come to the stage. I will continue this topic later on. Ms. Anju Kumari Mahato, please kindly be on stage for your presentation.
से आई थी। Thank you. A very good afternoon to one and all present over here. I'm Anju Mahato, and today I'll be presenting on the topic Perspective on the Quality of Life of Children Undergoing Occlusion Therapy and Their Parents, a questionnaire-based study which was done as a part of my postgraduate program at Shankar Nethralaya, Chennai. So these are the abbreviations that I'll be using throughout my presentation. I do not have any conflict of interest. So as we all know, amblyopia is commonly known as lazy eye, which is a neurological condition which arises during early development due to abnormal visual experiences. And the amblyopia treatment study defines amblyopia as a developmental disorder that affects the visual acuity, leading to reduced visual acuity most commonly in one eye and less commonly in both eyes, without any apparent structural abnormalities or ocular disease. And it is clinically diagnosed when the best corrected visual acuity is 6/9 or below in monoclinic Snellen optotype, or when there is a difference of 2 or more lines in best corrected visual acuity between the two eyes using logMAR optotypes. Prevalence: amblyopia is the leading cause of visual impairment in children and young adults. Ethnicity plays a major role in the occurrence of amblyopia, and in Nepal the prevalence is 0.35 as per 2016 survey. Based on the visual acuity, the amblyopia is graded on the severity based on the visual acuity. So the mild amblyopia is defined when the visual acuity in the affected eye is between 6/9 to 6/12, moderate when the visual acuity is worse than 6/12 but better than 6/36, and severe when the visual acuity of the affected eye is worse than 6/36. Types of amblyopia is defined on the basis of the underlying causes: anisometropic, strabismic, stimulus deprivation, and combined. The anisometropic amblyopia comprises the majority of the cases, being 50%. So as we all know, the treatment option varies as per refractive therapy, atropine panelization, Bangeter filter, occlusion, optical penalization, virtual reality, and dioptic therapy. In 1998, Peric launched RCT, and they said that the finding revealed that 2 hours of patching is as effective as 6 hours of patching for mild amblyopia. So to the best of our knowledge, there was no substantial literature examining the effect of amblyopia therapy on quality of life from a child's perspective. So this study currently severely relies on quantitative measures to determine the quality of life. The aim and objective of this study was to determine whether there is any change in quality of life of children undergoing occlusion therapy and to evaluate between the item scores of children version and that of the proxy parent version. This study was conducted in Amblyopia Review Clinic, Shankar Netralaya, Chennai, and it's a questionnaire-based study. Convenient sampling was done, and the study duration was for an year. We used Vijay Gotwal's approach and calculated the sample size, and we came to a conclusion that 36 patients were included, like 36 children and 36 parents. These were the inclusion and exclusion criteria of the study. We did a comprehensive eye examination, sensory and motor evaluation was done. Distance visual acuity and near visual acuity were measured, and then after 3 months of glass adaptation, we did the patching, and then we administered the APCOQ questionnaire first to the parent and then to the children to avoid bias. Moving on to APCOQ questionnaire, the first 3 questions relies on physical discomfort associated with patching. The other 2 relies on the activities of daily living. The subsequent 5 items relies on emotional and social experiences, and the 2 items, the bottom relies on the awareness and it's not related to quality of life. Ethical consideration was obtained, statistical analysis was done. Moving on to result, refractive error identified included myopia in 17 patients and hypermetropia in 19 patients. So in mild amblyopia, what we found was physical discomfort was reported as negligible with minimal impact on social or emotional well-being, as you can see in the box plot and the table next to it. In moderate amblyopia, social and emotional experiences were consistently positive with some parental concerns about the activities of daily living, as you can see in the box plot and the table next to it. In severe amblyopia, although fewer participants fell into this category, trend showed greater parental concern, but children themselves reported minimal challenges. This is what was interesting in our study, where we conducted a bubble graph. So larger bubbles on the top right corner, which you can see 5 on 5, indicates that both the parent and their children perceive a high quality of life, suggesting that the therapy was well tolerated, effective, and had minimal emotional or social impact. As I said in the previous slide, that 11 and 12 were not related to quality of life, but more of necessity of patching and the awareness. So this does not rely completely. Discussion. So the mother article, that was our Dutch study, and our study found that children reported minimal discomfort during the occlusion therapy, while the parents were much more concerned than the children itself. Impact on the social interaction, our study and the Dutch study observed that the majority of children were not statistically or significantly affected by the patch in terms of social interaction, and few instances of teasing or bullying may be due to cultural differences. Awareness of therapy necessity, what we found out was affecting compliance, and in contrast with our study, awareness level varied. It did not significantly impact the quality of life for the children as well as the parent. And in specific activities such as schoolwork or leisure pursuit due to patch, in both the studies we found out that minimal trouble was seen, suggesting fewer activity-related challenges. So the limitation was that in this study, the study relied on self-reported data from children and parents, which may be subject to bias. So incorporating objective measures of quality of life could reduce the bias. And lastly, the study did not include the long-term follow-up. It was a 6-month to 1-year duration. So further research and future research could benefit from more comprehensive longitudinal assessment in impact of occlusion therapy. I would like to conclude with the analysis indicated no notable differences between the various assessed domains and overall quality of life in children undergoing occlusion therapy, and this result suggests that occlusion therapy does not have any negative impact on the children's quality of life. Appendix. Thank you.
Thank you so much, Ms. Mahato. That was an insightful presentation on untouched aspects of amblyopia, which the children and family deal with. Now, I would like to invite Dr. Rohan J. Khemlani again in the stage to continue with his presentation.
Best thing to do, yeah. Okay. Yeah. Can we start? Yep. Present? Present? Maybe present. That's okay, that's better. Okay. Can I start? Start? Okay. Hello, everybody. Yeah, my presentation didn't want to load. Very sorry to keep you all waiting. And yeah, very sorry for the delay. So my name is Rohan. And about 2 years ago in Sengja, my team and I, we did a screening study at one of the rural villages, you know, just as a lot of people have, here have described already. This is a part of my team. So I work for a medical device startup called We Inc. And we have an international charity and research team, which I lead. And yeah, due to time constraints, I'm not going to describe further, but you can see on the screen. So the project was very simple. All of you are very familiar with the way it works here. Essentially, we collaborated with this man. His name is Dr. Buddhiman Shrestha, and his organization, the BM Foundation. And we, you know, we worked with this eye program, and we had over 600 kids in less than 5 days. And we had a lot of other members as well. So you all already know the geographical and, you know, topographical nature of, how these camps work. So I will not go into detail here. And essentially, you know, our setup, we had 4 tables. One for visual acuity, one for direct ophthalmoscopy, one for just, you know, paperwork and handing out medications. And one was my personal table. So in that table, we were using a device called the SEC, the Smart Eye Camera. It is a portable slit lamp microscope. We were also using the Welsh-Allen autorefractor, and we were using the eye care tonometer. Yeah, and these are just, you know, our demographic breakdown. We split the entire population into 4 groups. The first 3 groups were children, and the last group was for adults. Again, some numbers here for you to look at if you're interested. But essentially, the results state that, you know, we were looking at spherical equivalent and myopia rates. And what we found out is that the p-value was very high amongst the different age groups. So what we can guess and what we can really conclude is that age alone cannot serve as a predictive value of myopia in this population. There are far too many factors. Other than that, we also looked at visual acuity, and we found the same thing, that the p-value was quite high. And what that means is that, you know, that's probably because myopia levels are not strong enough to severely decrease the visual acuity. When it comes to eye position, gaze, we were measuring gaze, there was a statistically significant difference between the groups, and that means, the age is, of course, a very significant factor in eye position. Very interestingly, we also found a nystagmus case, horizontal nystagmus of, an albino young female, age 14. Also, we had 3 cases of bilateral cataract. Here are the images. Yep. And so, really quickly, of course, as you all know, that these screening programs are very, very vital. And of course, the big issues are the logistical challenges. What we have also found out is that the portable equipment are absolutely key when it comes to projects such as this. Also seeing that a lot of the pediatric population also suffers from cataract, which, to me was very new. It definitely highlights the need of accessible eye care in such areas. And beyond that, we would like to do more studies, and we would also like to find a way to really promote treatment. Because, we're all doing these eye camps, but the treatment, that's not happening at the rate that it should. And I would like to, quickly take some time to explain the device, the Smart Eye camera. Essentially, it's over here, you can see, it's a smartphone with an attachment on top like this, and it works as a portable slit lamp microscope. You can, like this. Yep. Now, to save time, I will not go into details, but you can have blue light, white diffuse light, all sorts of stuff. And the beauty is that it uses the light and the camera of the phone, unlike the other portable devices on the market, and that's why it's very small. Other than that, there's also a software in it. There's an app and a browser function, which is used for filing, similar to clinics. And we have telemedicine and AI diagnostics as well. This is how the app looks like. Essentially, we take a video. It is stored in the system. On the left, it's the app. On the right, it's the browser function. And for telemedicine, once we take a video and it's uploaded to the cloud automatically, I can ask associated accounts to give me feedback on it. And, for example, my supervisor, he is an ophthalmology consultant. So when I go out into the field, I see a case I don't really recognize, I ask him. And, if we have good internet connection, he can provide feedback immediately. AI diagnostics, this is, I will admit, this is, we're still in beta phase. It is still building. But for now, we have cataract grading and ACD measurement. So, we're trying to address the gap of eye care, which is heavily, heavily influenced by lack of equipment and personnel. And we're trying to do this on 3 levels. Number 1 is just purely portability. So eye specialists, such as yourselves, could use this device in rural areas. Level 2 is through telemedicine, where one does not require an eye specialist on site. As long as there's somebody capable enough, through telemedicine, they can receive consultation back. And lastly, long-term plan is AI diagnostics, where one wouldn't even require an eye specialist on, anywhere. And of course, there are many such devices on the market. The way this is different is that all these qualities of high image quality being one of the cheapest ones, simplest to use, and taking advantage of the phone's innate camera and flashlight, all of this, along with the software features I described, it beats the other models on the market. We're also very proud because the device was included in the official WHO document last year. We're using this device across the world. We really believe in evidence first. We always publish a lot of papers internally and externally through our global network of research partners. And these are the places the device is registered at. And I invite you to collaborate with us. We provide the device for free as long as 2 diopter, astigmatism lesser than minus 0.5 dioptric cylinder. So here is the workflow of the study. First, we collected the demographic data, and children who passed with the pocket vision screener were sent to open field autorefractometer to measure the refractive error and the accumulative lag. And children who failed to achieve 6/9 or better visual acuity after best possible refractive correction were referred to tertiary eye care hospital for further evaluation and management. So all the data were recorded in Microsoft Excel, and analysis was done using SPSS version 20.
0.0, and descriptive statistic was done to show the distribution of refractive error and accumulative lag, and one-way ANOVA was used to compare the difference in the age and refractive groups. So in the result, we found out of 990 children, 51% were male, 49% were female, among which emmetropia was 89.19%, followed by astigmatism, which was approximately 17%, myopia was 10%, hyperopia was 9%. And overall, the mean refractive error in right eye was 0.18 diopter, and in left eye it was 0.12 diopter. And overall, the mean accumulative lag in right eye was 0.76 diopter and 0.78 diopter in left eye. And since there was no significant difference between the right eye and left eye, therefore further analysis was done using right eye only. Here in the graph we can see the distribution of accumulative lag among different age groups, where we found accumulative lag was slightly higher in age 5 to 6 years, and it decreases until the age of 9 to 10 years, whereas again it gradually increases from 11 to 16 years. So comparing the accumulative lag between emmetropia and myopia, though it was higher in myopia, but it was not significant. So this study measures the refractive error and accumulative lag objectively using open field autorefractometer, which reduces the instrument-induced bias. And the average, in our study, the average accumulative lag was 0.76 diopter, which was slightly higher in myopia compared to emmetropia and hyperopia, similar to other studies. So the strength of the major strength of the study was it has a very large sample size, and in our study, the time that the children were exposed to near activities, amplitude of accommodation, and degree of heterophoria were not considered in our study, which can affect lag. So there is the scope that the study can be done to understand the correlation of accumulative lag with amplitude of accommodation and heterophoria. So in conclusion, we have provided the normative data using open field autorefractometer objectively, which can be used as the reference for further studies as a future reference. So I would like to sincerely thank Dr. Majid Kumar Thakur, Dr. Hom Bahadur Guru, Dr. Seskant Aryal, my colleagues, and entire Drishti Eye Care system for the encouragement and support. Thank you all for your kind listening and attention. Thank you.
Thank you, Mr. Chowdhury, for your valuable contribution in understanding accommodative function in children. Now, from pediatric ophthalmology, we are starting our journey into the optic pathways. So our first presentation for neuro-ophthalmology is by Dr. Sanjita Sitola. And Dr. Sanjita is a cornea specialist and neuro-ophthalmologist and her topic of presentation is swollen optic disc, when should I be worried? Dr. Sanjita, the stage is yours.
Thank you, Dr. Samata. And I'd like to thank Mechi Eye Hospital and the entire organizing committee for organizing this grand event, and I'm glad to be a part of it. Now, moving on to neuro-ophthalmology. Today, I'll be talking about swollen optic discs. When should I be worried? We know that swollen optic discs can range from a variety of disorders from benign to life-threatening as well as sight-threatening. So before coming to the topic itself, I'd like to just mention a few terminologies like optic neuropathy. Optic neuropathy refers to the dysfunction of the optic nerve characterized by decrease in visual acuity, visual fields, or abnormal color vision. The term optic disc edema refers to swelling of the optic nerve head, which is asymptomatic usually in the early stages, but it can have features of underlying disease like either intraocular inflammation or vital diseases. And the term papilledema refers to bilateral swelling of the optic disc, usually due to raised intracranial pressure. and the common diseases like intracranial space-occupying lesions, raised intracranial hypertension, or sometimes even grade 4 hypertensive retinopathy. Now today in this case-based approach, I'll be talking about a few cases. My first case is a 25-year-old primigravida at 34 weeks period of gestation, admitted for preeclampsia, with her blood pressures on the slightly higher range. She was referred to the eye department for the evaluation of papilledema. Her visual acuity, color vision, and visual fields were normal, and the fundus showed findings of early papilledema. Or is it? So now on careful evaluation of the optic nerve head, we can see that the optic nerves look slightly elevated. Now let's look at the vascular pattern. The vessels originating from the optic nerve heads are slightly different with increase in the number of vessels. And we can also see the characteristic lumpy, bumpy appearance on the optic nerve head. So we think maybe it's not papilledema or optic disc edema at all. This, on further evaluation, by doing a USGB scan, we can see a hyperechoic shadow at the level of the optic nerve head. Autofluorescence is present, and on enhanced depth imaging of the optic OCT of the optic nerve head, we can see a hypoechoic areas surrounded by a rim of hyperreflectivity with lots of other hyperreflective areas and horizontal hyperreflective lines, which is very, very characteristic of optic dystrusion. So in fact, this patient was a case of optic dystrusion, and by diagnosing this, we were able to avoid CS in this case. So we have to be aware that not all elevated discs are optic nerve edema, and we need a high degree of suspicion, and we can use alternative imaging, non-invasive tests before going to neuroimaging. Now our second case is an 8-year-old female who is presenting with sudden onset, rapidly progressive diminution of vision associated with painful eye movements. The visual acuity is markedly decreased in both the eyes, and the pupillary functions are lost, that is sluggish to direct and consensual light. So we know that it's not only disc edema, the optic nerve function is diminished as well. So it is some kind of optic neuropathy. So with this in mind, we went ahead and looked at the fundus. We can see that there is elevation of the optic nerve head with some flame-shaped hemorrhages characteristic of optic disc edema in both the eyes. So on the background of decreased vision and bilateral disc edema, we thought of bilateral optic neuritis and went ahead with imaging of the optic brain and orbit along with contrast enhancement. And we can see that both the optic nerves are taking enhancement in the contrast enhanced images, and we can see T2 hyperintensity along the whole of the optic nerves. So this is a case of bilateral long segment optic nerve involvement in optic neuritis, which is very characteristic of associated with MOG antibodies. So treated with intravenous methylprednisolone along with tapering dose of oral steroid. And at 1 month, she had regained vision of 6/6 in both the eyes. So the take-home message in this case is pediatric optic neuritis can often present with bilateral disc edema and is associated with ADEM and MOG, and it requires steroids for a longer duration of time to prevent recurrences. The third case is a case of 31-year-old female with headache aggravated in morning, especially when bending since the past 1 month. She also has transient blurring of vision lasting 3 to 4 seconds multiple times a day, and there is pulsatile tinnitus. Her best corrected visual acuity is 6/6 in both eyes. She does not have much of diminution of vision. The pupils are good, but on fundus examination, we can see there is marked elevation of the optic nerve heads with peripapillary hemorrhages and edema. So we went ahead with imaging in this case. So the image that we did in this case was MRI brain and the orbit with MRV, and on imaging, we found that she had a large intracranial mass at the CP angle, causing raised intracranial pressure and secondary papilledema. So in fact, this was a case of papilledema. And we saw in the visual field, there was presence of enlarged blind spot in both the eyes. Now briefly coming to the fourth case, he's a 49-year-old male, with headache and blurring of vision. The vision looks pretty good, the pupils are good, but apart from mild elevation of the optic nerves, we see there is a lot of hemorrhages around the vascular arcade. And on careful inspection, we can also see there's presence of hard exudates in the macular area and the macular star pattern. So now how do we go ahead with this in this patient? So we just went ahead with the blood pressure evaluation. The patient had high blood pressure in the range of 210 to 140. So it was a case of malignant hypertension presenting with grade 4 hypertensive retinopathy. So sometimes we have to rule out simple diseases like hypertension before moving ahead to investigations like MRI. My last case is a case of 33-year-old female with headache, nausea, and tinnitus for 10 days, and she's referred to the neuro-ophthalmic clinic for evaluation of disc edema. And on evaluation, we do see disc edema. But before, let's move on ahead with the examination. Her vision is slightly decreased. She has visual acuity of 6/18 in both the eyes. The pupils are brisk, no RAPD, no sluggish reaction, but on careful evaluation, we see that there is cells and in the AC and vitreous. Apart from that, we can see that along with disc edema, there's macular edema and inferior exudative detachment. So what could this be? So probably it's a retinal disease. And on careful evaluation, we found out it was a case of VKH. So sometimes there can be retinal diseases presenting with disc edema. So my final slide, I'd like to conclude by saying, so whenever we see a disc edema or elevated disc, first rule out whether it's really a true disc edema. Then further evaluate whether it's unilateral or bilateral. In unilateral cases, it's best to, if you think that it's a neurological disease, go ahead with neuroimaging. And the neuroimaging of choice is MRI brain and orbit with contrast. For bilateral cases, after ruling out raised blood pressure, we have to go ahead with neuroimaging. And the imaging of choice is MRI brain along with MRV. Thank you for your kind attention.
Thank you, Dr. Sanjita, for simplifying such a complex clinical scenarios with such a simplicity. Now, I would like to call our next presenter, Dr. Kripa Joshi, for her presentation. Dr. Kripa, the stage is yours.
Thank you, Dr. Samata. Today, my topic is risk factors and prognosis of isolated ischemic third, fourth, or sixth cranial nerve palsy at tertiary eye care center. There is no financial disclosure and no conflict of interest. On introduction, isolated ischemic cranial nerve 3, 4, and 6 palsy is the major cause of adult onset paralytic strabismus, which are mainly driven by different vasculopathic risks like hypertension, diabetes mellitus, hyperlipidemia, ischemic heart disease, left ventricular hypertrophy, and smoking. My main objectives are to identify the frequency and pattern of vascular risk factors in our Nepalese population, to compare distribution between cases and control, to assess effect of number of risk factors on its recovery, and to measure the recovery period and compare prognosis across 3 cranial nerve palsy. On methodology, study design, it is hospital-based prospective case control study done on 46 cases and 46 control patients. On population cases, all conjugative patients diagnosed with isolated ischemic nerve palsy are taken 3, 4, and 6. The study time period is from November 2024 to April 2025. For population control, age-matched control group were taken who received health examination during the same time period. Hypertension, diabetes mellitus, hyperlipidemia, ischemic heart disease, left ventricular hypertrophy were taken as positive when they were diagnosed by the cardiologist or physician, or if they are taking therapy. Patient is taken as a smoker if he is active smoker or if he is smoking since last 5 years. My inclusion criteria are ages more than 30 years, new onset of isolated ischemic nerve palsy, no history of trauma within preceding 3 months, No any neoplasm, aneurysm, or inflammation on neuroimaging studies. Exclusion criteria are all congenital causes of knob palsy, multiple cranial neuropathy, thyroid disease, multiple sclerosis, myasthenia gravis. Methodology, on continuing methodology, the risk factor group is grouped from 1 to 6 according to the number of risk factors involved. All patients who are under 50 years, they underwent MRI scan. The follow-up time period was done at 4 weeks, 8 weeks, and 12 weeks time period until there was full recovery with resolved diplopia and full extraocular motility was achieved. Coming to result, the most common age group involved was 50 to 59 years, with mean age 56.8 years. 60% of patients were below 59 years. Males were commonly affected with 71.7% of cases. Distribution of different knob palsy, 6 knob palsy was commonly involved, followed by 3rd knob and 4th knob palsy. Coming to distribution of risk factors among cases and controls, hypertension, ischemic heart disease, hyperlipidemia were commonly involved in cases group, and they were strongly associated with the knob palsy, followed by diabetes mellitus, left ventricular hypertrophy, and smoking. Cumulative risk factors in different knob palsy participant, it has shown that the cumulative risk factors, 3 were commonly affected, followed by the 4. Recovery time with respect to risk factors group, it has shown that the mean resolve time period, it increased with increase in risk factors group number 5, 6, 7, but the p-value was 0.154. Thus, the number of risk factors was not correlated with the time required for spontaneous recovery in this study. The recovery time in different knob palsy group in 6th, 3rd, and 4th knob palsy have shown that the p-value 0.11. Thus, the recovery time was statistically insignificant among 3 vascular groups. On result, 25 cases, they had underwent MRI scan. Among them, 14 had incidental findings of infarction, small vessel disease, gliosis, hematoma, thus suggesting common microvascular etiology in this age group. On discussion, the age distribution, majority of patients were below 59 years, with peak age 50 to 59 years, which was similar to the study by Jung J.S. Murchison study. The commonest knob involved was 6th knob, which was consistent with the all global data. The risk factors in our population was commonly hypertension, diabetes, ischemic heart disease, and hyperlipidemia, which matches the study done by Rucker, Rush, and the Jung J.S. study. Hyperlipidemia, ischemic heart disease, hypertension, diabetes were seen as 9 times more and 2 times more, which matches the past studies. And smoking was seen mainly in the cases which suppose the vasoconstriction and the hypoxia-mediated ischemic injury. On risk factor count was not directly linked to recovery. That matches the Kobashi R. et al. Study, but it was contrary to Jung J.S. study, which showed the risk factor is involved with the time recovery for knob palsy. The mean recovery time in our study is 6 weeks plus minus 2.36 weeks, which ranges from 4 weeks to 12 weeks time period. Similarly to the Kapo et al. Study, Akagi et al. Study have shown average 3 months recovery time period, and Connell et al. Study have shown 3 months time period and some delayed for up to 1 year. The most frequent combination was hypertension and diabetes mellitus, followed by hypertension, diabetes mellitus, and hyperlipidemia, which was similar to Jung J.S. and the Kobashi R. et al. Study. On conclusion, the knob palsy was paralytic strabismus was strongly associated with systemic vascular risk factors like hyperlipidemia, ischemic heart disease, hypertension, and diabetes mellitus, mainly in our population, which are seen even in younger age group, as the 30 years was not studied before. The cumulative vascular burden, likely it increases vascular vulnerability to knob palsy. Recovery usually occurs within 4 to 12 weeks with similar prognosis among the cranial knob 3 and 4 and 6. Number of risk factors did not predict the recovery. The early detection and systemic vascular screening is always recommended. These are my references. Thank you.
Thank you, Dr. Kripa, for concluding today's scientific session with such a clinically relevant presentation. Now we have come to the end of today's scientific session. I'd like to thank all our distinguished speakers for your engaging presentation and to our audience for their kind attention. Now the floor is open for questions and discussion. Okay, if there are no questions, we can move ahead with the token of love distribution. So we are presenting token of love to the chair, co-chairs, and all the speakers. And I must say this is a very thoughtful and environment-friendly token of love by Team Mechi. So first of all, I would like to request Dr. Srijana and Dr. Sabina to present token of love to Dr. Anand, sir. Okay, the one who gets the token of love earlier, they can have their choice of plant also. Now I'd like to request Professor Dr. Anand Sharma to present token of love to Professor Dr. Sabina Shrestha and Professor Dr. Srijana Adhikari. Similarly, I'd again like to request Professor Dr. Anand to present token of love to our co-chairs, Dr. Purushottam Joshi and Dr. Kavindra Bajacharya. Now I'd like to request Dr. Anand sir to present token of love to me. So I'd like to call upon all our speakers to receive their token of love. I'd like to request Dr. Sabina Shrestha to present token of love. To Dr. Sulabh Karki. Dr. Sulabh Karki, Dr. Rojita Parajuli, Dr. Rohan Khimnani, Dr. Sanjita Sitaula, Dr. Kripa Joshi, Mr. Anja Kumari Mahato, Mr. Roman Chowdhury, and Mr. Ajit Kumar Thakur. So there are few more token of loves to our speaker. I'd like to request Dr. Sabina and Dr. Anand to present token of love to Dr. Srijana. Next, I'd like to request Dr. Srizana and Dr. Anand to present token of love to Dr. Sabina. Now, I'd like to request Dr. Srizana to present token of love to Mr. Ajit Kumar Thakur. Miss Anju Kumari Mahato, please be on stage to collect your token of love. Mr. Roman Chaudhary. Dr. Kavindra and Dr. Purushottam, you have few more token of love as a speaker, so please collect it. I'd like to request Dr. Srizana and Dr. Sabina to present it. Okay. So at last myself will be receiving another token of love. So before we disperse, I'd like to request everyone to come on stage for a group photograph. So I'd like to request all the speakers to collect their certificate from Dr. Suchana. Okay. Dr. Sulabh Karki, please be on stage to receive your token of love.
At the very time, I would like to call upon Professor Dhaki Sherpa Madam. Please to come over here. He is our country representative, appointed country representative from Nepal. I'd like to call upon Dr. Kovindra Bhattacharya, our acquaintance from Nepal. Any other acquaintance present here in this session? Okay. Thank you very much. Thank you. Now, we have brought some sweets from Bengal. We will celebrate the birthday celebration. We will just distribute and in the meantime, Dr. Purushottam will give a few introductory notes. News about equine activities. Then we will start the session. In this session, Dr. Teju will be the moderator.
Hello? ल एकैछिन है त म भाषण दिँदैछु म एकैछिन बस भन न Namaste and good evening. A warm welcome to one and only Shopanda, who is synonymous with Equine India. The Equine India first conceived in UK in ICEH with Shopandada and Dr. Pradhan, who had thought over it and has come a long way, and it has done many social activities, and overall it has extended its cooperation with Nepal, and also the beauty of it is organizing a Rath Yatra to increase awareness about the eye blindness and its prevention. And I wish Equine to continue doing the generous activities and wish Sopanda very best of luck. Thank you. Namaste.
Thank you. My slide. Let me to start my keynote address. Just to recapitulate how we have started, how we have carried out, how we are carrying out, and what we like to do. In the meantime, I like to call upon one of our mentors of equine activities here in Nepal. Nobody is than Major Professor Joshi. Huh? Professor Rana, please do come over here, Professor Rana, and please take our felicitation on the stage. Please come. Major General. Major General. Camera on.
मुझे लीजिए और शुरू में
उहाँलाई बोलाउने हो पहिला छ अकोइनको सेसनको
खासै डक्टर बुझ्दैन
ए सरले गर्नुहुन्छ अरे बन्द गरेर
The theme of this particular session is promotion of Indo-Nepal friendship in the field of community eye health care services under the banner of Equine. India, Bangladesh, Nepal, Sri Lanka, We are bounded by political boundaries, but our health problems are almost equal. And at the same time, we have to work together beyond boundaries to tackle all those health problems, and especially in the field of community eye health care services. Here is a very brief interactive session where I would like to express before you how we have started and how they are going on. This is the goal of Association of Community Ophthalmologists of India. The goal is advocacy in community eye health care services in Indian subcontinent. The term advocacy requires much more explanation. But very simple explanation is that to reach the unreached population, to cater service to those who have got no idea where to go, when to go, how to go, and who will accompany me. This requires advocacy. Starting with only 7 ophthalmologists in Nepal in the year 1980, now Nepal has got more than 400 ophthalmologists. Starting with 1 or 2 eye hospitals in those days in Nepal, now Nepal has got more than 50 eye hospitals. The same thing in India, so also in Bangladesh and Sri Lanka. We have got no dearth of eye doctors, eye hospitals, medicines, state-of-the-art gadgets, as well as government and non-government support. Still we used to see that in each village of Indian subcontinent have got at least 1 cataract, at 3 cataract blind patients who require surgery today. In 3 or 4 such villages, we can find out 1 child who requires blind school education. Why? Because of lack of advocacy. That's why ACQUIN is working the lack of advocacy. Here I like to start my presentation today with salute to Sarathi. Who is the Sarathi of Nepal? The father of eyes, the father of vision in Nepal, nobody else than Professor R.P. Pokhrel, Ram Prasad Pokhrel sir. I bow down my head. Who has brought us in Nepal long before, and who has started the National Eye Care Program in Nepal by Nepal Netrajyoti Shank. So today's presentation is in honor of him, and once again I recall and pay my pranam to Professor Ram Prasad Pokhrel sir. Here is my good friend from whom I came to know about Nepal, and from whom I developed my ideas to develop this Association of Community Ophthalmologists of India to work beyond the border in India and Nepal. He is nobody else than Professor Damodar Pradhan of Janakpur. Myself and Professor Damodar Pradhan were the batchmates at the International Center for Eye Health, London, long back in 1995. This is the bridge over the River Thames in London, where in afternoon myself and Damodar went and roaming, and once we just stand and just discuss what would be the gain, what would be the outcome after our training from ICH on our return home. We decided, yes, we have to disperse our teaching, learning, whatever we have gained here to our countrymen. And that gave the idea to form Association of Community Ophthalmologists of India. And it took 5 years to develop this particular organization. So in the year 2000, we have founded Association of Community Ophthalmologists of India. You all know the eye health problem today is nothing other than cataract, diabetic retinopathy, glaucoma, refractive error, congenital abnormality, retinal diseases, ophthalmia. The same amongst the two countries. And at the same time, community eye health care of today is also same. In most of the places still there are a single window eye health practice by one ophthalmologist in the taluk level or village level. Still there are quackery. However, some private setup has developed with a group practitioner, and also the corporate hospitals develop, and so also we are searching for center of excellences. And our eye health problem of today will again be same. The same cataract, diabetic retinopathy, glaucoma, refractive error, congenital abnormalities, retinal diseases, as well as ophthalmia. Everything is there. So, what would be the community eye health care of tomorrow? The single window ophthalmic practice by single ophthalmologist will be vanished. It will be only by group practice. And corporate hospitals will take up the whole scenario, and there will be multiple centers of excellences all over this subcontinent. But having all those things, still the community is away from accepting or enjoying these facilities. Why? Because of the lack of advocacy. They don't know where to go, when to go, how to go, and who will accompany them. That's why Aquan has come up. If you just look at the logo of Aquan, you can just see at the center there is lotus. Lotus is the symbol, as per Hindu mythology, is the good eye, Padmalochan. And you can see at the below of the lotus, there is an eye with a bright people. This is not a cataractus people, but a shining people which can see. And around that, you can see so many tents are there. These tents are nothing but the communities at the urban area, whether in the rural area, whether in unreached areas, anything. And within the tents, in the hearts, there are the people who are looking at all those black moons. They cannot see the moon properly, the full moon. That's why Aquan like to give them, everybody, a lotus eye, a shining eye, so that they can see the moon. So Aquan is going all over Indian subcontinent. It is not a organization, it is a movement, lifetime movement for advocacy in Indian subcontinent. That's why you can see in the center, we are the terrorist affected areas of Kashmir. We are in China border, you can see in the corner. We are in Mizoram, we are in Andaman and Nicobar, we are in Koraput, we are everywhere. We Aquanians are there, and we are with our goal, we are going everywhere. You can see, here is, we are at the Myanmar border in Tripura, where we are going door to door to examine the children. We are in Nagaland, Arunachal Pradesh, near China border. We are going door to door to examine the children. We are in the blind schools. I first came to Nepal and Kathmandu in the year 1998 at the Asia Pacific Conference. Before that, I came to Lahan in the year 1995. Following that, we started. My good friend Dr. Sunu Dulal was always with me. Professor Sunu Dulal joined me in my journey on ocular leprosy. That is my subject of favorite subject. And myself and Sunu went to so many leprosarium, so many leprosy settlements in Nepal and examined leprosy patients together. We had been to Lalgaon Leprosy Hospital. We had been to Anandaban Leprosy Hospital in Kathmandu and so many places. Then we started our journey. Our journey was enlightened with the presence of His Excellency, the High Commissioner of Nepal, in our first Aquan NNJS Indo-Nepal Friendship CME in Kathmandu in the year 2012. And then we have got different conferences. I can still remember Mechi in the year 2017 when we came here the annual conference of Nepal Ophthalmic Society, where more than 40 young ophthalmologists of Nepal have enrolled as the live member of ACOAN. Now our live membership roll of ACOAN from Nepal is more than 70, and those 40 have enrolled in Mechi. This time also I am very much desirous to enroll a maximum number of ophthalmologists in this particular conference in ACOAN family. We have got different interactive CMEs with our Nepali colleagues near Indo-Nepal border. In Karsiang, Darjeeling, in the year November 2018, we have got a beautiful ACOAN Indo-Nepal Friendship CME in Karsiang on diabetic retinopathy. And last year, in 2024, under the dynamic leadership of Professor Daki Sherpa, we have got Indo-Nepal Friendship Conference in Kathmandu by the gracious presence of the first president of Nepal, nobody else than Professor Ram Naresh Jadhav, where a big group of Indian delegates participated from different states of India and made a successful conference there. And ACOAN is always with us, always with the Nepali colleagues, and always like to felicitate the Nepali ACOAN members, to encourage them, to motivate them. Once again, I recapitulate and like to congratulate the Nepali ophthalmologists, a big group, more than 70 Nepali ophthalmologists participated in Bilaspur conference, 13th annual conference of ACOAN in Bilaspur in the year 2023. In Puri, Odisha, last year in 2024, here again, more than 30 Nepali delegates, ACOAN members participated in our ACOAN Puri conference, the 14th annual conference. And this time in Palampur, Himachal Pradesh, under the dynamic leadership of Dr. Tenshu Malla, the secretary of Nepal Netrajyoti Sangh, more than 20 ophthalmologists from Nepal, our ACOANian members, participated and were honored by the health minister of Himachal Pradesh with our different ACOAN national awards. In this way, ACOAN is going on with its friendship with Nepal and going to different parts of Nepal with its activities. Make our awaz of community eye health service to echo in each and every corner of Indian subcontinent, as the Kirtan of Govindaji temple in Imphal, Manipur is going on round the clock for centuries together. I am proud to say, with our Drishtiraj Jatra, we have so far covered 6 districts of Nepal. We have been successful to go 10,000 feet above sea level in Jamsam district near Muktinath temple, in the particular school which was established by the kind patronage of the then President of India, Sri Pranab Mukherjee. We had been to so many other districts in Nepal. We had been to Bharatpur, Viratnagar and other places. In this way, let the lamp to light long. As Gangarati at Rishikesh is going on for years together. So our joint venture with hand to hand, the Nepali ophthalmologists, the Indian ophthalmologists and everybody will fight for sight for the benefit of 2 countries so as to prevent the needless blindness in the subcontinent. I call upon all of you at ACOAN Darjeeling 2026, the 8th annual meeting of ACOAN West Bengal State Chapter on 5th April, Sunday in Darjeeling. There will be no registration fee, and the organizing secretary is your beloved sister, Dr. Anupama Vishwas, who has his graduation from Nepal, India, and post-graduation from Nepal. Anupama will be there. So it's our cordial invitation to deliver ACOAN West Bengal State Chapter oration at ACOAN Darjeeling 2026. And lastly, it's my pranam to Professor Padma Shri Professor Taraprasad Das sir, our great honorary Accoinian, to grace this occasion. At the same time, I like to announce you the warm invitation to Accoin Silver Jubilee celebration in Kolkata from 24th to 27th of September 2026. 24th to 27th September 2026 in Kolkata. I have got a dream to assemble at least 2 ophthalmologists from each of the districts of Indian subcontinent. In Indian subcontinent, we have got 1400 districts. In Nepal, there are 72 districts. If we can assemble at least 2 ophthalmologists from each of the districts of Indian subcontinent and 1 ophthalmologist from each of the developing and developed countries, it will be a great celebration. I had already talked with Padma Shri Dr. Taraprasad Das only a couple of days back in Gorakhpur. I had the proud privilege to have the words from Sir Harminder Singh Dua of their kind participation. So I request each one of you to participate and to discuss in which best way we can go on with Accoin. Once again, I like to tell you, Accoin is not an organization. Accoin is a movement towards positive eye health care, a lifelong movement so as to reach our goal, advocacy in community eye health in Indian subcontinent. Thank you very much. Looking forward to see you once again in our future meets. Thank you, sir. May I now request Padma Shri Professor Taraprasad Das to give a line of 2 words of blessings in this particular session. Okay. Now, Professor Dhaki Sherpa will tell on the prevalence of glaucoma in Nepal. Before we go to start with the talk of Dr. Dhaki Sherpa, I beg the kind burden of Padma Shri Dr. Taraprasad Das to come over the dais and to take our honor. Sir, 1 minute আসুন। এক মিনিট আপনি এসেছেন, আপনাকে তো আসতেই হবে। I'd like to call upon Dr. Purushottam Joshi, President Nos, to join us as well as Professor Purushottam Joshi. As well as Badri Babu. Purushottam, please to come. Yes, that's why it's a proud privilege to have you here.
मेरो प्रेजेन्ट यो अन छ स्लो गर खोइ त्यहाँ आएन ए भाइ गएन त त्यहाँ आएन
Dhaki?
हाँ?
Dhaki? Professor Dhaki, please start.
म उता जाने के त आई एम हियर
Respected chairpersons, co-chairpersons, and all the delegates,
My presentation is a glaucoma scenario in community level in Nepal. So coming to the introduction, glaucoma is second leading cause of irreversible blindness. Number of people with glaucoma worldwide will increase to 111.8 million in 2040, more in Asia and Africa. And Nepal fall in this category. Difficulty in early diagnosis, likelihood of irreversible loss, glaucoma is an important public health problem. According to the Nepal Blindness Survey, it was a third cause of blindness. 3.2% of the total blindness was due to glaucoma. Prevalence of glaucoma was 1.9% in Bhaktapur glaucoma study, and POAG accounted for 68 and PSCG 22.67%. Secondary glaucoma accounted for 9.33%. Among the subject with primary open-angle glaucoma, 96.08% was not previously diagnosed. A hospital-based study conducted in southeast part of Nepal concluded that 25% of the glaucoma patients were visually impaired or blind at the time of presentation. In a population-based study, the glaucoma prevalence was 0.938% and POAG was 0.5 and PSCG was 0.12, secondary glaucoma 0.25 and ocular hypertension was 0.5% respectively. And in another study done by Suraj Sakya et al. Showed that the primary congenital glaucoma was 5.68%. Primary and congenital glaucoma was most common form of glaucoma among children. Majority of the cases of primary congenital glaucoma presented late after 8 years of age with significant vision loss. In a study done by Sherpa et al. In Nepal Eye Hospital, secondary glaucoma were 22.07% of all newly diagnosed glaucoma. 81.35% were blind due to secondary glaucoma, blindness which is avoidable by effective screening, timely referral and effective treatment. Now coming to current limitations, difficult geographical terrain, lack of awareness about the disease in the general population, limited effective tools and resources to detect the disease in remote areas. Non-compliance is also a big problem among diagnosed patients, which is associated with older age, financial hardship, advanced disease, and less frequent follow-up. Glaucoma awareness is 2.3% in the general population, significantly low in female according to the population-based study. The situation at the community level is alarming because of low awareness plus poor attention given to the detection in community eye health programs. Now, what are the probable solutions? Nationwide popular-based study required for the accurate estimation of the magnitude of blindness, glaucoma due to glaucoma in Nepal. To increase the human resource interested in glaucoma, leadership capabilities of glaucoma fellows in each province of Nepal has to be strengthened. More than 20 to 40 well-equipped hospitals, eye departments of medical college provide a strong infrastructure. Eye departments should be well-equipped in glaucoma diagnostic tools. The available data suggests that the prevalence of POAG is higher than PSCG in community. Public health education should be a high priority in the prevention of disease, prevention of vision loss due to glaucoma. Sakya Veda et al. Recommends the screening individual with hypertension and diabetes for glaucoma. Screening family members of those with glaucoma would be most cost-effective than widespread screening. Thapa et al. Showed a simple age-based glaucoma screening method incorporated into cataract screening community clinics is successful in detecting glaucoma and providing treatment. Implementing portable visual field analyzer plus teleophthalmology, artificial intelligence may be of great help regarding glaucoma diagnosis at the grassroots level in Nepal in future. We can win a battle if we are determined and united. So let us join hands together to reduce the burden of glaucoma worldwide. Thank you.
Thank you, Professor Daki. In the meantime, I'd like to call upon Professor Anand Sharma, our member of ACOIN, to receive our felicitation. Professor Anand Sharma, please to come. I'd like to request Professor Badri Badu to felicitate Professor Anand Sharma on behalf of us. Hey, photo of our. Any more Aquanian present here? Now I would like to request Professor Badri Badu, the veteran academician of Nepal, to give a brief note of ongoing teaching and training program in Nepal, his own ideas.
Thank you very much, Dr. Sopan Samanta. It's always a happy moment when Dr. Samanta is with us, because he is so well prepared for everything, and he is known to everybody, every member of the ophthalmic community in Nepal. He called me a day or two before, then asked me if I could deliver a lecture on community ophthalmology education in Nepal. Is it okay? But the time was too limited. Therefore, I would like to suggest him to keep this topic for Kolkata next year. ACOIN Silver Jubilee is going to be celebrated next year in Kolkata on the 24th, 25th, and 26th of September 2026. I would like to propose everybody, let us try to be there. It is, of course, a great privilege to have Dr. T.P. Das, Tara Prasad Das, one of the renowned ophthalmologists of India, with us here in this conference. It will be a very great learning opportunity. With this, I would like to conclude my remarks and thank everybody. Thank you.
The conclusive note of Indo-Nepal friendship in the field of community eye health care services and the bondage of ACOIN with NOS, I would like to request Dr. Kovindra Bhattacharya to give his concluding address. Dr. Kovindra Bhattacharya is an ACOINian from Nepal and is hailing from Lumbini.
Thank you, sir. So it has been not more than, I think, 6-7 years I met Professor Dr. Samant Savan, and I found him very much inspiring for all the ophthalmologists in the world, I must say, especially for working in the community field, because the energy he has, and as Professor Badhu sir said earlier, sir is planned with everything, this type of felicitation things and everything. He is prepared. Even sweets we have already tested. So how much He's energetic, and his vision is for many years. Now, Silver Jubilee is going to be held in Kolkata. Not only more than 1 month, equine conference in Palampur has been completed. Now he is looking for the Darjeeling equine chapter, and then Kolkata, always working and looking for the conferences, gathering of the ophthalmologists from not only India, all the subcontinent, including Nepal. A very much impressive work you are doing. In fact, you are in the heart of many ophthalmologists, at least in the Asian countries, I think, and in the subcontinent of India. You are inspiration for us, and we are hopeful that the vision you have, let it be spread in all over the community, so that no people will remain blind for the avoidable and treatable causes of blindness. Let us work together, and as one of your followers, one of your student, I will also like to continue your foot sprint, because as I'm one of the community ophthalmologists, as outreach director at Lumini Eye Institute, my work is to provide good service in that province in Lumbini. For that also, I will always be following your advice and your vision. We will also try to implement. And lastly, I would like to thank once again Nepal Ophthalmic Society, Equine, Sopan sir, and the sir here on the dais, and all the distinguished delegates over here. We have 2 days remaining. Let us enjoy our conference, and the cultural program now is going on. We have to attend there, and tomorrow we have conference and gala dinner, and day after tomorrow also half day we have. I wish for the grand success of this conference. Thank you so much, sir.
We would like to conclude the session with a very small video of 2 minutes only on our equine ongoing dream project, Equine Drishti Ratha Yatra in Indian subcontinent. Sound? No, sound a bit sundar. Please organize this Drishti Rath Yatra in each and every district. Inform us, we are there. Our mantra is the mantra of Swami Vivekananda. Uttishtito Jagrato Prappo Varannito. Awake, arise until you reach your goal. We have to make our countrymen to arise and to avail all the eye health care facilities in their vicinity. Everything is there. So far we have reached 130 districts of India. We have to go everywhere. Thank you very much for your kind patience and participation in this small equine session. We'll beg your kind stand up on this podium, and we like to take a group photograph. Please be kind to come over here and to take a group photograph. All please come and have a group photograph.
For this equine session, we have a small token of love for Professor Chopin Samant. I would ask Professor Badu sir to give him the token of love. Bhai, eta photo khich. To Professor Dr. Suraj Samser Rana. And to Badri Badu sir by Professor Sopan Samanta. And the presenter, Dr. Daki Sherpa by Dr. Sopan Samanta. Professor Dr. Daki Sherpa. Token of love for Dr. Pravindra Vajracharya.
Sir, aa jaiye.
Thank you.